Welcome to the Practice of Medicine podcast from the Southern Medical Association. Since 1906, the SMA has had a singular mission to provide medical professionals with the resources they need to learn from each other, and in so doing, to improve the overall quality of patient care. The Practice of Medicine podcast is just one of the ways we do that, as we discuss a wide range of topics, including the Physicians in Training Day in the Life podcast series. To learn more about the SMA's many other services and educational initiatives, please visit us at sma.org.
Join Dr. Doris Lin as she discusses the readiness of hospitalists to assess and evaluate resident progress, a topic on which she has written an article for the April 2021 issue of the Southern Medical Journal. In this podcast, she also explores the role of faculty development in the evaluative process, as well as provides strategies to help hospitalists assess and evaluate trainee progress. In addition, she offers insight regarding the current state of evaluation of learners and where it could be headed in the near future. Thank you so much for joining us, Dr. Lin.
Thank you for having me.
You noted in your article on hospital readiness to assess and evaluate resident progress that there has been a rapid growth in the specialty of hospital medicine. Could you please describe further your concepts why the increase in hospitalists across the U.S. healthcare system?
So, I think the hospitalist movement and the term hospitalist really originated in the mid-1990s, and I think it grew for a couple of reasons. I think at the time, outpatient primary care physicians were splitting their time between their outpatient practice as well as seeing their own patients that were hospitalized. And I think in order to grow their outpatient business, hospitalists were able to take on the responsibility of seeing the hospitalized patients. I also think the growth happened because of, in the early 2000s, the ACGME, or the Academy Accreditation Council for Graduate Medical Education, or ACGME, developed some duty hour restrictions as well as caps on the number of patients that residents could see. So academic institutions and other hospitals, that led to the need for more inpatient coverage, and I think hospitalists also filled that need. And now, nowadays, I think hospital medicine as a career choice has remained popular for our graduating internal medicine residents.
Dr. Lin, we noted that you had been honored with the Norton Rose Fulbright Faculty Award in Teaching and Evaluation. This award reflects your keen interest and capabilities in medical education and trainee evaluation. How did you develop this interest through your career?
So I've been a hospitalist, clinician, educator for over a decade, and the first few years out of residency, I sort of split my time between direct care and I always worked at academic institutions where I was always able to attend on inpatient teaching services also. The last 7 years or so where I work currently, now I'm primarily on inpatient teaching services. And so through all these years of experience and interaction with learners at all levels, residents and medical students, that really just kind of solidified my interest and focus in medical education.
Great, thank you.
This is a two-part question. Resident physician evaluations for clinical competency and achieving important milestones has seemingly never been so important in medical education than it is right now. What do you think is the state of evaluation of learners at this time, and where do you believe it's headed in the future?
So current internal medicine evaluations are really based on ACGME milestones, which track the growth and progression of each competency during training. And the ACGME developed 6 core competencies, and those include practice-based learning, patient care, procedural skills, system-based practice, medical knowledge, communication skills, and professionalism. And then incorporated into the milestones and competencies on evaluations are EPAs, or entrustable professional activities. And these are activities so that evaluators and faculty filling out the evaluations, they're activities that are recognizable to them. So for example, can this resident elicit an appropriate history and physical for the patient's chief complaint? Can this resident develop an appropriate differential diagnosis and carry out management plans? So, that's where we currently are with evaluations, with the EPAs, core competencies, and the milestones. as far as where, and as well as, typically on the evaluations, not only are there the sort of objective numeric component of it, but usually there's also a narrative or comment box at the end of the evaluation where the faculty can fill out or include narrative comments. As far as your second part of the question, where it's headed in the future, there are updates in the ACGME milestones that they term ACGME milestones 2.0, which for internal medicine is coming in July of 2021. And those it includes many different updates to their core competencies. And just one or two of the examples include things like digital health is going to be included in the patient care core competency. And then in professionalism, is the resident able to recognize their own emotional and physical challenges at work? So there's some updates in the milestones, and that's termed the milestones, ACGME milestones 2.0.
This has been really an interesting facet of the discussion. Thank you.
Lynn, it would seem that assessment and evaluation of resident physicians and fellows, I presume, in the hospital setting would be a natural responsibility for hospitalists. Do you agree with that? And if so, how do you encourage your colleagues to see the value in this responsibility?
So yeah, I do agree with that. I think with the increasing presence of hospitalists as attending on ward services, it's natural that we've now been tasked with the important responsibility of assessing and evaluating our resident trainees. And I think for the most part, those hospitalists who attend on inpatient teaching services hopefully have an interest in medical education, which is the reason they're on the teaching services. I do think there are significant differences in maybe how attending supervise, assess autonomy, and evaluate just based on individual attending characteristics. Maybe they're an early career hospitalist versus someone who has years of experience. And I think those are areas where faculty development may play a role in that. And so in order to educate, maintain, and sort of encourage our hospitalists to see the value of this responsibility.
As a two-time program director, I've seen over the years the complexity of resident evaluation increasing. Do you think that the ability of a faculty member to develop and assess competency is a realistic goal?
Yeah, I think the evaluations are competency based. And with the addition of the entrustable professional activities, I think with some faculty development in these areas for hospitalists as well as other faculty who do the evaluations and work with residents, I do think it could be a realistic goal.
In your article, you mentioned the role of faculty development in the evaluative process. Would you please expand on that topic a bit more for us?
Sure. So in the perspective, I focus on two main areas where I think faculty development may help. The balance of supervising and providing residents autonomy, which I think remains a persistent struggle in academic medicine, as well as a second topic where I focus in the perspective on our ability to provide meaningful feedback, evaluation and feedback in order to promote the growth of the resident. So I feel like these two areas could play an important role to develop for faculty development.
Dr. Lin, we appreciated your raising the concept of the, quote, persistent struggle between supervision and autonomy in the professional and clinical development of resident physicians. Can you summarize for the listener the element of that challenging struggle and describe possible solutions for achieving balance?
So I think for hospitalists in particular, the struggle is partly, as hospitalists, we're used to managing patients independently. And so when we're on the inpatient ward services, we have to, give up some of that control over to the residents. I think a second issue is that we have a very limited amount of time where we're there attending on service, and potentially that could be 1 to 2 weeks. And in that very limited amount of time, we may or may not know that resident and their skills. And so we have to really decide pretty quickly how much leeway or micromanaging to give that resident. In some ways, as far as solutions, I think in some ways with the advent of like the electronic medical record has helped in order for us to, sort of do background supervision without overtly affecting or interfering with their autonomy. But a couple of other solutions I sort of describe in the perspective. I mentioned 2 articles published in the literature, 2 strategies. One that was by Farnan et al., which was a framework they developed in 2010, specific to internal medicine residents and attendings. And they described they put together a framework they termed superb safety. And in it, they delineated, different halves. The superb half was really to help the attending physician in order to supervise. And it discussed different elements of supervision, including setting expectations for when the attending should be notified, or anytime there's uncertainty, please contact the attending. It also discussed aspects of supervision, like planned communication, making sure the resident knows that the attending is easily available. And then the safety half really discussed times when the resident should contact the attending for input, particularly on certain topics that are difficult, or maybe the resident lacks experience, like transitions of care or end-of-life issues, as times when the resident may need to contact the attending. So that was one of the frameworks I discussed in the article in terms of trying to balance supervision and autonomy. There was a second article I discussed in the perspective by 10K, and it was a more recently published article in 2020. And what they used was Miller's pyramid, which is a framework developed 30 years ago, and really characterizes 4 levels of assessment in medical education. The quote, know, knows how, shows how, and does. But what they mentioned in the article is that because we now use entrustable professional activities, we really need to add the term is trusted at the pinnacle of the pyramid. And what that means is the attending should be able to observe the learner's ability to cope and adapt to changing situations that we face as physicians every day, and to know when to ask for help in attending input and have the confidence to deal with the unexpected. So attending observations of those skills in the resident. So they recommended that is trusted at the top of the pyramid. So these were just two of the frameworks and models that I thought could potentially be a solution in educating hospitalists how to provide supervision and assess autonomy.
May I ask a sort of a follow-on question, and that is, how has the pandemic affected the educational interaction between trainees and hospitalists, and the ability to assess the care of the trainees when there are so many difficulties on the COVID wards and so forth?
So I think as far as working at an academic institution, I think we were very lucky to have our internal medicine residents. They were at the front lines helping during a very, what still is a very overwhelming and extraordinary time in our healthcare system. I think there were impacts to medical education, particularly during the times that the COVID pandemic was peaking and patients were high. We had high volumes in our hospital. Some of the obvious impacts were that during that time we weren't always able to round in a group because we were trying to limit exposures of the virus to ourselves, other medical personnel, and to the patients. And so we weren't always able to round in a group as a person. And so we sort of lost that team dynamic, which I think is so important in internal medicine. In addition to that, I think they lost, they couldn't, as far as residents, they couldn't social gather. They weren't able to have sort of large group educational activities in person anymore, which I think is important for residents to have that interaction during residency with their peers. So there were a lot of things that were affected by the pandemic. As far as did it affect the evaluation process, I think, with the team dynamic affected and in-person group rounding and other activities affected, some of the direct observation by the attending of the resident was obviously also impacted.
Dr. Lin, could you tell us about some of the assessment and evaluation strategies that hospitalists might utilize in their teaching roles with the resident physicians?
So evaluation strategies I discuss in the perspective. I mainly focused a lot on feedback and narrative feedback and the comments because I feel like that's an area we could all improve upon, myself included, in the if you read the self reflection and the perspective. So as far as feedback delivery, it's published in the literature that faculty tend to focus too much on praise and don't really capture entrustment themes. And a lot of the feedback faculty could include, vague comments like, myself included, I do this. You're a great resident, or you work well with, you worked well with the team, but they're not really behavior specific or actionable comments. And so I really focused on that as far as areas that could be improved. And other solutions that I've just been working on myself, not only the ability to write better narrative comments that would be helpful to the resident, but also giving more verbal feedback. At the end of their 1 to 2 weeks, at the end of their 1 to 2 weeks on rotation with me, I try to meet with them in person to give them feedback. And right when I sit down with the resident, before I even start giving my feedback, I try to frame it as constructive feedback. I say this is all going to be constructive, not meant to be mean or negative, so they understand this is really constructive feedback to help them. And the second thing I do before I start giving any feedback is ask them to self-reflect on their own strengths and weaknesses during the 2 weeks that I worked with them, 1 to 2 weeks that I worked with them. And I find that a lot of times they themselves actually bring up things that their weaknesses and the things that they've been working on, which were things that I was going to, discuss in the feedback session. So I feel like if they bring it up first, then it makes for a much easier discussion.
How, Dr. Lin, did you come by your self-reflection, and can you summarize that for us on how to become a better faculty evaluator? You've already covered some of the issues, but are there any others that you would like to share with those who are listening as far as lifelong learning as a faculty member, other things that you might suggest to improve skills and approaches?
So the self-reflection of the perspective was really me just sitting down one day as I was filling out another evaluation that, over the years, I was becoming complacent and really just kind of marking things on autopilot and then not really writing very constructive feedback that would be helpful to the growth of the resident. And so recognizing I was doing that during my self-reflection and just recognizing that I needed to work on those things. And like I talked about, writing vague comments, which were unhelpful. So, I think even though I have years of experience, it was helpful to self-reflect in order to be able to improve on my own verbal feedback, recognize that I was writing things that were vague and unhelpful and to work on that. And also to work on my own supervising skills. And I talked about a couple of the strategies before to continue to work on how I supervise, how I observe behaviors when I'm working with the residents, but I may not be capturing it on their evaluations. So, kind of working on all those things all together. Because, what we're trying to do is help the resident mature and grow during their residency and improve their skills, which is the ultimate goal.
Excellent. Have you considered using your insight and perspectives and experience to actually develop training modules for your fellow hospitalists in assessment and evaluation of residents?
Yeah, so that may be the next step. And you make a great point. I think faculty development is necessary. And, I thought about it, and that may be a next step for us. We have a large hospitalist group. And so I think at varying stages of their career, we have many early career hospitalists and some that are more experienced who've been working on teaching services. So I think faculty development would be very helpful and something I've thought about doing.
Look forward to seeing your product in the future.
Thank you.
I want to thank you very much for joining us today. This has been a very informative and important discussion, I think. And so before we conclude, Dr. Lin, do you have any final comments you would like to convey to your colleagues and our listeners of this podcast?
we have an important responsibility as hospitalist clinician educators, just not to become complacent in these skills of supervising, assessing autonomy, and evaluation, because our ultimate goal is really to train the next generation of physicians to be successful and capable of independent practice.
We hope you enjoyed the practice of medicine. For more episodes in this series or SMA's The Business of Medicine podcast, go to sma.org/podcasts or subscribe to us on Apple Podcasts, Google Podcasts, Spotify, or wherever you get your podcasts. For more information about SMA's physicians in training, please visit sma.org/pit. And thank you for joining us.